I recognize the gentleman from Virginia, Mr. Griffith, 5 minutes for questions.
Thank you, Mr. Chairman. I appreciate that. According to the CBO, Medicaid will cost the federal government $5 trillion over the next 10 years, with as much as $638 billion of that directly linked to the expansion of Medicaid from PPACA. Recently, the governor of my state, Governor Bob McDonnell, laid out the need for vast reform to make Virginia's Medicaid program more cost-effective before the Commonwealth can consider an expansion. The state legislature set up a system where they can consider an expansion if these reforms are met. And there were 5 tenets that he laid out for Medicaid reform. 1, service delivery through efficient market-based system, including more managed and coordinated care. 2, reducing financial burdens to the state by getting an assurance from the federal government that expansion will not increase the national debt. 3, maximize the waivers that currently exist to achieve administrative efficiency through streamlining of payment and service delivery. 4, obtain buy-in from healthcare stakeholders in the state for statewide reform. And 5, achieve greater flexibility by changes to federal law, including more value-based purchasing, cost-sharing, mandatory engagement in wellness, and preventative care, the development of high-quality provider networks, and flexibility around essential health benefits. It's a mouthful. The bottom line is these reforms that Virginia is now discussing are par with the plan laid out by Chairman Upton and Senator Hatch to provide states with more flexibility to implement their Medicaid programs in a way that makes sense for them while better controlling costs. Ms. Verna, how do you feel about these Medicaid reforms that Virginia is currently exploring? What can we do to help the states better serve the vulnerable populations that need Medicaid, while giving the states the flexibility that improves the quality of their program, promotes access, and gets costs under control?
I think that Virginia has all the right elements there. I think they've covered the span of identifying incentives for providers and individuals. But I think the key part there is that they're going to need flexibility from the federal government to implement those pieces. So that'll be a critical component. But I think they have the required elements of a reform package.
So you think that is a good?
I think it's a good
step.
approach. I'm glad to hear that they've also included the individual in that piece. I think that's important. They've got the providers. They're looking at the benefits. And I think they also recognize the important role that the federal government plays in this to making that happen.
Now, as a part of that flexibility for the states, how do you feel about a situation where, yes, we want to reward folks for doing the right things, but what if they can consistently do the wrong things? Do you think that there ought to be some kind of a stick that can also be applied in that flexibility if somebody continually goes to the most expensive health care provider because they just don't seem to care that they're running up the costs?
Absolutely. I mean, I think but you have to use those sticks appropriately. You have to be mindful of the population. I think that the carrots and sticks work differently with different populations. I think a disabled population, those are a little bit harder to apply.
Absolutely.
However, as we're talking about Medicaid expansion and able-bodied individuals, I think those are probably more appropriate populations that those could be effective.
And that does make sense. For everyone, there's always a lot of debate around when states can and cannot implement cost sharing. From your perspectives, when does cost sharing work, and what can be done to really allow the customization of cost sharing at a local level?
I think cost sharing needs the most work. I know CMS did put some proposed rules out that increase the cost sharing levels. I think it's very rigid structure. It only requires co-pays. There's no opportunity to enforce premiums for people below 100% of poverty. There's no flexibility to do value-based, where you would be able to vary the co-pays depending on the types of services. And I think the enforcement piece is critical. I mean, what happens with co-pays and the way that they have it structured is that it ends up being a decrease in the provider reimbursement because providers can't collect it.
And let me go to the other side. I only have about 45 seconds left.
I'll add to that. My hospitals would be remiss if to that particular question about cost sharing, I didn't mention that we need to do some reforms to EMTALA, because EMTALA has turned into sort of a blanket reason to be able to use the emergency room without regard for appropriate use.
Sure. Dr. Thompson?
I think we're on a path to change. The administration's proposed rule, which we have incorporated into our private option, is on the right path. I think it is a complex system, and at some point cost sharing if you're only making $6,000 a year, does become a barrier to access. The other piece that we've had to work with on our providers and our workforce strategy, if you're working an hourly job and the doc's only open 8 to 5, you're going to end up going to the emergency room. So we need our docs having after-hours clinic and weekend clinics, or people are going to do exactly what you would expect them to do. They're not going to lose an hour's wage to go to the doctor in the middle of the day when they can go to the emergency room at night. So this is part of a total system change. It involves workforce, it involves access, and most importantly, it does involve finance.
I thank you all for being here, Mr. Chairman. I yield back.
Chair, thanks, John.